During a vaginal childbirth, the first stage of labor lasts about 12 to 19 hours and starts when the fetus settles into the pelvis. In response, the pelvis begins to efface and the cervix becomes thinner and dilate or widen. During this time, there could be strong regular contractions every 5 to 20 minutes, accompanied by lower back pain and cramping that don't go away. Mucus plug might be observed and the bag of water ruptures, as manifested by sudden gush of fluid. At the beginning of stage 2 of labor, lasting from 20 minutes to 2 hours, the cervix is fully dilated to 10 centimeters. The baby's head has moved beyond the cervical opening into the birth canal. Because of the resistance met by the baby, positional changes are specific, deliberate, and precise as they allow the smallest diameter of the baby to pass through a corresponding diameter of the woman's pelvic structure. The baby is the one responsible for these position changes, or what we call the cardinal movements. The cardinal movements of labor are engagement, descent, flexion, internal rotation, extension, external rotation or restitution, and expulsion. During labor, these movements not only are sequential, but also show great temporal overlap. First, engagement. This is the mechanism by which the biparietal diameter, which is the greatest transverse diameter in an occiput presentation, passes through the pelvic inlet, or what we call station 0. The fetal head may engage during the last few weeks of pregnancy, or not until after labor commencement. In many multiparas and some nulliparas, the fetal head is freely movable above the pelvic inlet. The head is sometimes referred to as floating or unengaged. A normal-sized head usually does not engage with its sagittal suture directed anteroposteriorly. Instead, the fetal head usually enters the pelvic inlet either transversely or obliquely. The fetal head tends to accommodate to the transverse axis of the pelvic inlet, whereas the sagittal suture, while remaining parallel to that axis, may not lie exactly midway between the symphysis and the sacral promontory. The sagittal suture frequently is deflected either posteriorly toward the promontory or anteriorly toward the symphysis. Moderate degrees of asyncellatism are the rule in normal labor. However, if severe, the condition is a common reason for cephalopelvic disproportion, even with an otherwise normal-sized pelvis. Successive fetal head shifting from posterior to anterior asynclitism aids descent. Second, descent. This movement is the first requisite for birth of the newborn. In nulliparas, engagement may take place before the onset of labor, and further descent may not follow until the onset of the second stage. In multiparas, descent usually begins with engagement. Descent is brought about by one or more of 4 phases, which include first, pressure of the amniotic fluid, second, direct pressure of the fundus upon the breech with contractions, third, bearing down efforts of maternal abdominal muscles, and extension and straightening of the fetal body. The third cardinal movement is flexion. After the engagement and descent, the fetus will flex. The chin is in contact with the thorax. As soon as the descending head meets resistance, whether from the cervix pelvic wall or pelvic floor, it normally flexes. With this movement, the chin is brought into more intimate contact with the fetal thorax, and the appreciably shorter suboccipito-bregmathic diameter is substituted for the longer occipito-frontal diameter. Fourth, internal rotation. This movement consists of turning of the head in such a manner that the occiput gradually moves toward the symphysis pubis anteriorly from its original position, or less commonly, posteriorly toward the hollow of the sacrum. Internal rotation is essential for completion of labor, except when the fetus is unusually small. The time of internal rotation is completed by the time the head reaches the pelvic floor, approximately 2/3. It is also completed shortly after the head reaches the pelvic floor in about another 1/4. In the remaining 5%, rotation does not take place. In multiparous, when the head fails to turn into reaching the pelvic floor, it typically rotates during the next 1 or 2 contractions. In nulliparous, rotation usually occurs during the next 3 to 5 contractions. Extension. After internal rotation, the sharply flexed head reaches the vulva and undergoes extension. When the head presses on the pelvic floor, 2 forces come into play. First, it is the force exerted by the uterus and acts more posteriorly, and the second force is supplied by the resistant pelvic floor and the symphysis and acts more anteriorly. The resultant vector force is the direction of the vulvar opening, thereby causing head extension. This brings the base of the occiput into direct contact with the inferior margin of the symphysis pubis. With progressive distension of the perineum and vaginal opening, an increasingly large portion of the occiput gradually appears. Immediately after its delivery, the head drops downward so that the chin lies over the maternal anus. External rotation or restitution. If the occiput was originally directed toward the left, it rotates toward the left ischial tuberosity. If it was originally directed toward the right, the occiput rotates to the right. Restitution of the head to the oblique position is followed by external rotation completion to the transverse position. This movement corresponds to rotation of the fetal body to bring its bisacromial diameter in relation with the anteroposterior diameter of the pelvic outlet. Thus, one shoulder is anterior behind the symphysis pubis and the other is posterior. Finally, expulsion. Almost immediately after external rotation, the anterior shoulder appears under the symphysis pubis, and the perineum soon becomes distended by the posterior shoulder. After the delivery of the shoulders, the rest of the body quickly passes. When the anterior shoulder is tightly wedged beneath the symphysis, then shoulder dystocia is diagnosed. As a denouement in the normal delivery, the baby's head will rotate to face the mother's back. During an active labor, the uterus is divided in an active segment that contracts, pushing the baby downward, and a flexible passive segment that remains relaxed, stretching to provide more room for the baby to pass through. When the crowning happens, episiotomy is done via midline or mediolateral to facilitate easy passage of the baby. As the baby's head passes through the birth canal, it molds into an elongated shape that would resolve itself in a few days as the calvarium shifts back into place. After the baby's head exits the birth canal, the head and shoulders will rotate to help the shoulders pass through the birth canal. The shoulders are delivered one after the other to fit the pelvis. Once the shoulders are out, the rest of the body of the baby slides out easily. Soon, stage 3 of labor happens after the cutting of the umbilical cord. It lasts from 5 to 30 minutes and mild contraction help aid in the expulsion from the uterus. Now, a new life emerged.